So I want to welcome you all to Let's Talk Clots, which is Thrombosis UK's contribution to World Thrombosis Day. We are absolutely thrilled to the response that we have had. So we've had nearly 3,000 people register. 2,500 are in the UK, and then 500 come from 59 countries outside the UK. Yesterday, we had phenomenal audiences, 500 for the morning symposiums. And it's really great to be able to welcome Dr. Ander Cohen to give our plenary lecture. Not he's used to giving plenary lectures, I have to say, and he will, if we have time, take questions at the end. And he tells me he's been looking in his crystal ball about what the future holds for thrombosis and thrombosis prevention. I think everybody knows Ander. Ander is the epidemiologist of the thrombosis world, and also he runs huge numbers of clinical trials from phase 1 to phase 4, and he's a chairman and member of many international steering committees. He's also produced over 500 publications and is on the editorial board of several thrombosis journals. He graduated in Australia, as you all know from his twang, but he now works at Guy's and St Thomas's. We're privileged to have him in the Thrombosis and Haemophilia Centre here. There's lots more I can say, but you don't want me to witter on. We want Anders to start so we can hear what he's got to say. Ander, over to you. Thank you for coming today.
Thank you very much, Beverly, and wonderful to be giving a talk to the Let's Talk Clots meeting, which, as Beverly says, is very well attended, and I'm grateful to Joe and Beverly and Thrombosis UK for inviting me. I'm going to discuss what's new and on the horizon in anticoagulation for both prevention and treatment of venous thromboembolism. I think it's an important topic because there's lots going on. I'm not going to be able to cover everything, but I'm going to cover some of the areas where I have an interest. And so this is a slightly biased view, but I've had a good look at the literature and tried to represent that too in this talk. These are my disclosures for research support, consultancy and honoraria, and Speakers Bureau and scientific advisory boards. And I'd like to point out that I receive funding from many of the companies that make anticoagulants and reversal agents. So I'm going to sort of move around a bit in the talk, but I would like to talk about factor 11 inhibitors. I'd like to talk about ethnic groups in studies and more also about social factors as well as economic factors, but I'll come back to that. I want to talk about risk assessment in medical thromboprophylaxis and also in cancer-associated thrombosis. I'd like to start with standardization because I think it's the most important, easy, fixable trick that we can all do to improve our research and make sure that our research is relevant. And then I'll talk a bit about the prevention and treatment of VTE, anticoagulation antidotes, and then a little bit on AI and ML because all the major journals now have an AI branch, and we're seeing AI in even our own journals. So I'll discuss a recent deep learning study in the Journal of Thrombosis and Hemostasis. So the unmet needs are really, I think, the common data elements, and that's standardizing what we look at and how we describe not just the diseases and conditions we're interested in, but also how we measure the outcomes and how we define outcomes. I'll show you a paper later on where they go into great detail about a deep learning technique in major bleeding. But I read the paper again last night, and there is absolutely no definition of major bleeding within that paper. And that's a real weakness, because we have to define all these things very carefully. What is major bleeding? What is death? What is death by bleeding? What is death by thrombosis? And we just haven't got good definitions. And I know the ISTH is working on that. I also want to talk about ethnic and cultural groups, because I think that they are important when it comes to considering disease processes and understanding the differences in different groups. I'd like to talk a bit about the derivation cohorts for prediction of risk. I think we've gone down the wrong path with medical thromboprophylaxis. I think the derivation cohorts we used for predicting risk were the wrong cohorts, and I'll explain why. I've written a paper about this, and then I'd like to move on a little bit about improved risk benefit and possibly factor 11 inhibitors, a bit about AI, and I'll also discuss a little bit about reversal or antidotes. These women are twins. They look pretty much the same, but they're probably not the same, because these are my two twins. The one on the left is warm and emotional and sitting with my sister, and she takes after her father. The one on the right, identical twin, is cold and steely and takes after her mother. And although they have the same genes, they do not have the same personalities. And that's true when we're measuring things. And if we look at a series of papers, and I did look at a series of papers a few years ago, I looked at COVID-19 and VTE publications, and there was minimal common data elements. You could not relate one of these papers in big journals, Chest, JAMA, Lancet, JTH. The definitions were not standardized. And if you're not standardizing definitions, you cannot amalgamate data. You can't be sure that you're putting the same patients together. And that makes a huge difference in understanding the risk factors and the treatments. And this is something that JTH, and not JTH, the ISTH are working on. And I'd encourage you to get involved in understanding that. The common data elements can be specific to the disease. They can be specific to the setting. So whether things are in outpatients and how you define outpatients or inpatients. They could be for policymakers. They could be the way the study is done. They could be the outputs, the actual definitions of the outputs. And it's key that we understand these things. Moving on, I'd like to talk a little bit about research in ethnic and cultural groups and in many respects, financial groups. And what I mean by financial groups is understanding socioeconomic factors in patients, because it definitely makes a difference. All these things make a difference. I'll show you some evidence of, it says ethical, it should be ethnic, not ethical. Some cultural factors we see and financial factors. So this is a study that we presented recently at the ISTH. We were looking at patients who had received a first prescription of a factor 10A inhibitor, which could have been, in this study, low molecular weight heparin or a DOAC like apixaban, rivaroxaban, or edoxaban. 500,000 patients, but when we excluded patients where we felt weren't suitable for the study for various reasons, they didn't have proper linkage to different databases, or we didn't know enough about them, we hadn't followed them for more than a year, or that they also used other anticoagulants. We ended up with 250,000 patients. And in those patients, they had various conditions from atrial fibrillation, venous thromboembolism, non-mechanical cardiac valves, and adult congenital heart disease. But the key here is we use the UK Clinical Practice Data Link, and we link that with inpatient care, and we link that with the Office of National Statistics. But it gives us, and we always ask for it, socio-economic data. And that means we can adjust for socio-economic data. Now, I won't show you the socio-economic data, but we see that the rates of disease vary depending on the socio-economic group. And that's an important consideration when you're thinking about major programs to prevent illness. These were the results. Now, and this is quite interesting. In these 250,000 patients, we had almost 14,000 major bleeds by hospitalisation and almost 4,000 bleeds by the ISTH definition. So about 3 and a bit to 1. So why am I talking about this? Well, you pick up a paper from United States, which really looks at the number of major bleeds, and that's describing those 13,890 patients. They're the patients who are hospitalised. They can't look at things like transfusions, things like drops in hemoglobin. They don't have that data. They know who's admitted to hospitalisation because that's recorded. So when you're looking at bleeding rates in United States or other parts of the world which only measure hospitalizations, you might see a bleeding rate for hospitalization of 6%. But then you look at ISTH bleeding definitions in clinical trials and you'll see a bleeding rate of 2%. And you see, that's why when you're looking across studies, you have to know what's what. The other thing is we can look at, which they can't look at the States because they don't have death certificate data, is we can look at mortality. And if you look at the third column of my table, we can characterize all the bleeding into different areas, and we can look at the mortality, and then we can look at what's called case fatality, which is the number of deaths per bleed. And we can see that intracerebral bleeds have about a 40% death, similar to what was seen in the clinical trials. We can see that hemopericardium has a mortality of 73%. Retroperitoneal bleeds, which include aortic ruptures, 78%. Critical site bleeds, unspecified, which was mainly thoracic aneurysms, 63%. So we can see what sort of bleeds have the highest rates. Upper GI bleeds have slightly higher mortality than lower GI bleeds. But we can also look at risk factors. And this is our adjusted subhazard ratios, and adjusted subdistribution hazard ratios are a result of doing regression with a program that allows you to look at competing risk. And we would look at competing risk of mortality that wasn't related to bleeding. So here we've got ISTH major bleeding. We can see we've got 17 factors with an adjusted subhazard ratio of 1.5. That's a 50% increase in bleeding. And that's when you adjust for it, not just everything in this table, but everything in the next table as well. So we recognize 40, 17 greater than 1.5, and another 23 where there's somewhere between a 14% and a 44% increase in risk. Now, that is a lot of risk factors, and they're all adjusted for each other. But we initially looked at 140 risk factors. So we've actually got, out of the 140, we've got it down to 40 that are significant when you adjust for each other. And what I wanted to point out, because we're talking about ethnicity, is that those of the Black ethnicity had a 38%, a significant independent increase in risk for ISTH major bleeding when compared to whites. And there was also an increased risk in Asians, but that didn't reach statistical significance. So ethnicity is important. The other thing we recognised were these 4 factors that were associated with reduced bleeding risk. So DOAC therapy on the right here was reduced risk compared to low molecular weight heparin therapy. If you had major surgery in the previous 90 days, you reduce risk because major surgery patients are healthier than the general population. We see that in hip replacement. They live longer after the first 3 months. Consistent with all the literature, and I've read 4 or 5 papers in the last year, proton pump inhibitors long-term are protective. We can see about a 16% reduction in major bleeding, and a history of receiving other anticoagulants, not factor Xa inhibitors. And that's because those patients that have received those anticoagulants and haven't bled are the ones that you might swap over. Those patients that bleed disastrously have already been flushed out by that sort of early anticoagulant therapy. I'm going to move on to prediction of risk, primary prevention of VTE, and secondary prevention we'll discuss a bit. And just to summarize my thoughts on this, the prediction of VTE, primary prevention, that we use, except in United Kingdom, but that's used throughout the world, the IMPROVE, the PADUA, they're all from populations where 20 to 40% were getting thromboprophylaxis. And what does that mean? That means that when they assessed risk in those populations, the high-risk populations had it reduced by getting thromboprophylaxis, and the low-risk populations appeared to be closer to the high risk because they were not getting thromboprophylaxis. This is a major error where you're trying to predict who gets a therapy when all the high-risk patients in your group are already getting therapy. And that's why PADUA and IMPROVE and a lot of these risk assessment models do so poorly in real world or in observational data. They just have been derived in the wrong populations. We need to go back to basic risk. We need to use either what the UK is doing, or we need to go back and look at the clinical trials and look at the placebo arms and see who was at risk. And we've published that data, and it used to be used before PADUA and IMPROVE and IMPROVE DD, which is really complex, were used. The same for prediction of bleeding. We only have one decent score from the IMPROVE bleeding score by Hervé de Coussis, but they received thromboprophylaxis. For prediction of recurrent VTE, we've got better data, and we've just produced some new data, which I won't show you today, that predicts recurrences over time. And same for prediction of bleeding. But the problem with the bleeding is that there are too few patients. There's only about 30 patients in a lot of the studies. There might be 100 patients, but we're not looking at thousands of patients with bleeding, and we need to. And some of these things, like the the American College of Chest Physicians, just have shopping lists of published data, and they just add up scores. It's completely unscientific. So fortunately, we've got some new data on this. We have to think about improved risk benefit. We've had a significant leap with DOACs, but what about factor 11 inhibition? And I'm going to review the data on that. What about adding them to antiplatelet agents? There's a few studies that are doing that. What about on their own? or in combination with other anticoagulants, which would be quite brave. And also we have randomized controlled trial data from one of the antidotes. So here we are, Beverly. It doesn't look like me, but I think that's Mystic Meg, and she's looking into the crystal ball. And we're going to have a look at factor 11 inhibition, antidotes, and a little bit on AI and machine learning. So here, I'll start with my conclusions. There's plenty of them, and they're in different formulations, and they have varying modes of action, different pharmacokinetics and pharmacodynamics. They seem to work best in venous disorders. They may have a role in arterial disorders, but it's not clear. They probably have less bleeding, that's for sure. But their role in SPAF is unknown, but there's good epidemiological evidence to say they probably should work in SPAF if you get the dose right. So why do we need these new drugs? Because even with DOACs, major bleeding is about 2 to 3% per year. Intracranial bleeding is about 0.5%. And there's bleeding predicts cardiovascular events, and I've got some new data on that, which I won't show you today. This is what we've got. And I'm not going to go through all the different drugs, but we've got ones that work on transcription, and they are the ASOs, and they're antisense oligonucleotides. We've got the antibodies, and the antibodies sometimes work against factor 11, sometimes against factor 11A. And then we've got the small molecules, which are receptor blockers, and there's various ones, but I'm going to discuss asundexian and milvexian. But first, the epidemiology. I think this is impressive. This is the work by Georgi et al., and it looks at the genetic predisposition to low factor 11 levels and its associated reduced risk of ischemic stroke and VTE. And what we can see here is this is comparing the low levels with the normal levels. These are odds ratios in the y-axis. We can see VTE is very low. It's about 1/10 of what's expected. Ischemic stroke, about 45%, and MI, no difference. We can see the odds is here 1. But when we look at the stroke subtypes, it's mainly cardioembolic stroke that's reduced, a bit of difference to small vessel stroke, but not much difference to large artery, and no significant differences in the vessel strokes, the artery strokes, but definitely a significant difference in cardioembolic. So in theory, it should work. It does work in VTE. This is a meta-analysis by Knopp and colleagues looking at VTE prevention and total knee replacement, about a 60% reduction in bleeding, but also a 40% reduction in venous thrombosis. So the top forest plot with the summary is venous thromboembolism. The bottom one's clinically relevant bleeding. If you look at those summary statistics, still quite broad sort of range, but they are significant at 40% and around 60% reductions in thrombosis and bleeding. So definitely a risk benefit there. And the other thing to say is when you look at milvexian, and they've tested quite a lot of doses in milvexian, you can see when you start with the twice daily that there is definitely a dose response. And so those blue bars are actually the venous thromboembolism frequency, and they decrease as the dose increases. Not such an impressive change with the once daily, but certainly when you get to 200 milligrams once daily, much less than what was seen with the enoxaparin. So dose specific. If you look at the epidemiology in AF patients, first of all, on the left, we've got patients without AF, no differences in the cumulative probability of stroke. But in those patients with AF, we can see that over time, there is a difference. But look early on, look in the first couple of years, because this is Mendelian randomization. I know it says time since randomization, but this is genetic randomization or Mendelian randomization. And what you're seeing here is that early on, sorry, I'll go back. Early on, there's no difference. So are these differences in AF and stroke with low factor 11 compared to higher factor 11 or normal factor 11? Is this something that is very subtle that takes years to appear? And that's the concern, I think, for the companies, particularly after the results of the Oceanic AF, which I'll show you next. First of all, Azalea. Azalea was an interesting study using abelacimab, and it was a phase 2 in AF. The top line is rivaroxaban, and the bottom two lines are 2 doses of the antibody abelacimab, and abelacimab reduced bleeding compared to rivaroxaban. But that's not the interesting thing, because when we look at the bleeding, I think it's interesting to see the breakdown. We see a reduction in all aspects of bleeding, but in particular, GI bleeding. 2.1 with rivaroxaban, 0.1 with abelacimab. And also, we don't see a huge difference, but maybe possibility of reductions in intracranial bleeding, but not significant in this study. And then if we look further at stroke, we don't see any differences. So with a higher dose of abelacimab, you don't see any differences in stroke. And if you compare ischemic stroke, which is what you would hope a factor 11 inhibitor would reduce, we actually starting to see, well, a non-significant 60% increase when compared to rivaroxaban. So this is another hint that perhaps the factor 11 inhibitors are not so good in atrial fibrillation. We also have the secondary stroke study with milvexian, and this is in patients who have had a stroke and they're preventing secondary strokes, so not atrial fibrillation patients. And if we look at the bar charts on the right, over time, with increasing doses and the incidence of stroke versus placebo, 5.5% for placebo. And as you go across, really they're the sort of differences you might expect by charts. So nothing to indicate reductions of stroke in the short term in a randomized controlled trial. Asundexian, which is another small molecule, primary efficacy, ischemic stroke or covert infarcts. In this study, we can see placebo on the right, 19%, no real differences, no observed dose response. And then if we come on to asundexian in the Oceanic AF, this was the big shock at ESC. Apixaban, the stroke rate was 0.4% in AF patients, asundexian over 3 times higher at 1.3%, a hazard ratio of 3.8. So although if we look here, we can see some reductions in bleeding, like ISTH major bleeding was reduced by almost 70%. The whole purpose of giving these drugs is to reduce stroke. So there's a lot of head scratching here. Is this the right dose? Were these the right patients? What about the time factor? In actual fact, I think that many people think it may be a dosing issue, but it also might be a time issue. So leaving factor 11, I think my summary is they're good. The inhibitors are good in VTE. Where I'm not sure in AF, and I'm certainly not sure in arterial disease. It may be a much longer term game as shown by the epidemiology. let's have a look at antidotes to oral factor 10A. And that, what I mean by oral factor 10A are apixaban, rivaroxaban, and edoxaban. Well, we've had three major studies with andexanet alpha. We've had an XRA, an R, and that was like a proof of concept. We saw a reduction in factor 10A activity for both apixaban and rivaroxaban. And NEXA4, we were able to look at the outcomes with respect to excellent or good hemostasis, and we saw very good results in all patients, patients with intracranial hemorrhages, patients with GI hemorrhages, and patients with other hemorrhages. But it's the phase 4 study, an XRI, that I think has really created some interest, and we published this in the New England Journal this year. This was the study. There was no standard of care. We couldn't have a direct comparison. We had to compare andexanet alpha to usual care, because usual care for some centres and recommended, there was no recommended therapy. So some centres were using PCC, some centres were using other things, tranexamic acid, you name it, fresh frozen plasma. But actually, when we got the study going, more and more people became interested in offering PCC as the comparator. So within the usual care, 86% of the patients received PCC, and these were mainly patients with intracranial hemorrhage, and we concentrated on intracerebral hemorrhage in the end. And our hemostatic efficacy was not having an increase in hematoma volume, so it had to be less than a third, not having a worsening of the NIHSS points at 12 hours, and not having rescue therapy. And these are the results. We had good efficacy, which is excellent or good, in almost 64% of andexanet and 52% of usual care. And at that point, the adjudication committee told us to stop the study. They recommended we stop the study. That was our primary aim. We had reached that highly significant 8 in 1,000 p-value, and there was an increase of about 11 per 100 patients increased hemostatic efficacy. The downside was that there was an increase in thromboembolic events, 10% with andexanet, closer to 6% with usual care, significant at the 5% level or the 4.8% level, and there was an increase in ischemic stroke, an increase in myocardial infarction, but there was fewer DVT and PE in the andexanet alpha group. And furthermore, we looked at whether andexanet alpha did what it's meant to do, which is reduce anti-10A activity. And if we look at the red line here over time, there was a 94% reduction in factor 10 activity with andexanet alpha. Usual care, about a 27%. So pretty much what you'd almost expect over time. So definitely the andexanet alpha helped. The key here was that in these studies, the reduction in hemostatic efficacy was associated with a significant reduction in the size of hematoma increase. And if we look at the size of hematoma increase, for every mil increase, there's about a 6% more likely to have a 1-point increase in MRS. And for every 10% increase, about 16% increase. And if you get more than 33% growth, then its predictive value is about 70% for an MRS of 6 or 4 to 6. And same with the other measurement, the 2.5 mil growth, about an 81%. And these were all reduced with andexanet alpha. Now, the MRS score goes from no symptoms to moderate disability, but then by 4 to 6, you're looking at severe disability, and 6 is death. So we think that a reduction in the increase in ICH volume and the reduction in growth is very important. We also were able to look at risk factors for hematoma expansion, and this is some work that we presented in Arizona early in the year, and in particular, large baseline hematoma, shorter time from symptoms to treatment, and higher pre-scan hematoma growth rates. The other thing we could look at is overall rates of hematoma expansion, and you could see that they were 25% with andexanet and almost 40% with usual care. So the number needed to treat was about 7. For thromboembolic events, as I said, it was 10% overall versus 6%. The number needed to harm was 26. And we were able to look later this year in Basel in Switzerland at hematoma expansion and mortality. And we could see that hematoma expansion in red there was associated in increased hematoma expansion, but that mortality was associated with increased hematoma expansion. It was not so clearly associated with thrombotic events, although that's not significant. We can see that early on there's not an increase. Maybe later the curves start to separate. So we're trying to learn from this. This is a post hoc analysis. We're trying to learn from this and work out which patients are likely to have the maximum benefit, which patients are likely to have thrombotic events, and how we can ameliorate that by reintroducing anticoagulation at a sensible early phase. I'm just going to talk to you briefly about gastrointestinal bleeding, because this is the indication in England. In Scotland, and it's GI bleeding and intracranial hemorrhage and other hemorrhages, but NICE restricted the use of andexanet alpha to GI bleeding. And I just thought we published a paper this year on GI bleeding, and we had 109 patients in Annexa 4 with GI bleeding, mean age of 76, mainly AF patients, about 3 hours between dosing and bleeding. And hemostatic efficacy in the whole group was 82%, but we were particularly interested in those patients taking antiplatelet agents or NSAIDs or COX-2 inhibitors, because these are the ones that have gastric erosions that might do better with andexanet alpha. These are the ones where there's sort of oozing or often inflammatory response to the medications in the gut. And their hemostatic efficacy was 89%. So that's reassuring. Of course, the hard thing is deciding which patients are the right ones to give an antidote. And we know that you can look at the patient and look at their clinical signs and say, look, they're pale, they're still bleeding, they're unstable, they're not responding, they've got tachycardia, oliguria, and unconsciousness, or a low hemoglobin. And we know they all are helpful indicators of patients with severe or life-threatening GI bleed. But we've also looked, and we presented this in September at the ESC, at this 250,000 factor 10A users, and we looked at the 3,800 ISTH defined bleeds, and there were 1,312 deaths. And what I want to point out is that age over 80 these are all adjusted hazard ratios on the right. What I want to point out is that the usual suspects also predict death. So age, smoking, MI, heart failure, vascular disease, dementia, COPD, kidney disease, and metastatic disease. So these factors also help you recognise who's going to die after a major bleed. And I think things like this should be taken into account. Just moving on to other factors that are related to reversal. There was a very interesting paper, Peter Rietzma's group by Schroeder et al. This year in JTH, which looked at minimally modified human blood coagulation factor 10 to bypass the direct factor 10A inhibitors. I mean, these guys have been looking at snake venoms for ages, and they've looked at the differences between the snake venoms that might affect 10A and cause thrombosis, and other ones that might affect 10A and cause bleeding. And they found for the prothrombotic ones that there were certain changes, and they've been able to get one of those nice vats and produce, get cells to produce modified factor 10 to substitute the phenylalanine for either alanine or isoleucine or acerine. And that's what you see. And you can see, without going into details, that in each of these situations, whether it was blood from AF patients or VTE patients, whether they received apixaban or rivaroxaban, there was improvement in the thrombin peak, and there was improvement in the lag time. So other things there as well. I've banged on a bit. I might just go on to risk assessment, and I'll just quickly go through risk assessment so I can leave some time at the end for questions. So risk assessment is a bit of a dog's breakfast, I think, and that's really because when we look in cancer patients are different. We always do our studies, we separate cancer patients from non-cancer patients for VTE, active cancer, I mean. And here we've looked at what we might use when a patient comes into a clinic, that we might use has bled, or we might use VTE bleed. And if we look at the C statistics, 0.57, 0.56, 0.56, they're just not good at estimating risk of bleeding in cancer patients. Same with all the others. This is another study by Maria de Winter, externally validating. You can see the dark blue's low risk, the intermediates red, and the highs the lighter blue. And it really, I mean, depending on what score, you just get a range of findings. Maria went on and did this study where she looked at the Hokusai study, and she found that the strongest factors for bleeding were genitourinary cancer, GI cancer in patients that received edoxaban treatment, and GI toxicity and age and kidney and metastases. I mean, good, but really this is not useful because it relates to edoxaban and what we see with edoxaban. But at least it was it was the first study in cancer. Andreas Munoz Martin, he's done the Predict AI, and he's used read technology, which is a form of AI. I mean, remember in AI, it's the 3 R's. It's reading, writing, and arithmetic. And the reading is the optical AI for histology and X-rays and scans. The reading is this. This is natural language processing, or NLP as they call it here. And that's just looking at words and trying to make sense of them and the order and the emphasis. And then arithmetic is machine learning, basically. So it's just numbers or data. And this is a combination of natural language processing and machine learning. And what they came up with is they looked at a lot of patients, and they came up with this bunch of things that actually predict not just recurrence, but bleeding. So age, metastases, some of the things in the Karana score, platelet count, leukocyte count, hemoglobin, and so on. And very helpful. But when they checked it out, these receiver operator curves, they're nice, but they're showing significant differences, but they're still around 0.5, 8, 0.6. So they're just good in terms of discrimination. we did a whopper study, which we published last year. We had 15,000 patients with cancer-associated thrombosis. We had over 500 bleeds, 161 major bleeds, and 376 requiring hospitalisation. And we come up with this sort of table, and it looks complicated, but that's just the significant factors in the model compared to the non-significant within those domains. There are actually 140 factors we looked at. This is a summary, but I'll show you a better summary. These are the cancers that were independently associated with bleeding: GI, central nervous, melanoma, kidney, prostate, cervix, bladder. And these are the conditions that were independently associated with bleeding: minor surgery, anemia, history, coagulation, GI disease, minor trauma, and metastases. So we're able to recognise, and you can come up with incidence rates by risk groups, but you can show this differently too. You can show just low, medium risk, what percentage of the population, and what is their incidence rate per 100-person years. But these are 6-month incidence rates. And this can also be demonstrated in a sort of speed dial. And what you can recognise with this, see that red zone, you can recognise that about 2% of the population have an incidence rate of 56.5 over 6 months. So that would be an incidence of 28 over 12 months. And so you can recognise those that are high risk and maybe just only treat them for 3 months. Whereas the intermediate group, you might think 6 months, maybe more. Whereas the low risk group, maybe you can continue anticoagulation. You can give people points with our score. But there are other scores available. And this is the one I wanted to talk to you about. So remember, this was the deep learning one, but this was impressive because they used all sorts of different models, and some of these models looked at risk over time, as we did in our study. So you're looking not just at baseline, but you're looking over time. And useful and reasonable C statistics, 0.8, not dissimilar to what we saw. We got, well, it was better than what we got. We got 0.7, but better than 0.6. But how do you interpret this? There's no definition of major bleeding. There are only 118 bleeds, and they said that limited their deep learning. So interesting stuff. AI, ML pops up everywhere, but we need to involve lots of people in this. And I've always said that it's not just patients and clinicians, it's ethicists and lawyers, and you want to make sure you're not getting into something where you're disadvantaging people, because we don't know necessarily how we come to the conclusions because of the opacity of the analyses. There's all different sorts of ways to do it. The best way to do it is not supervised learning, because you're not going to learn anything. You're just going to tell it what to do. It's not unsupervised learning, because that's a fishing exercise, but it's what we generally do, semi-supervised learning, where we say, this is what we know, tell us what we don't know. And this sort of diagram is one of the studies we did in atrial fibrillation, but what it shows is that we were trying to predict atrial fibrillation. So we looked what happened from the point of following them. And so we looked at what we call time varying, but we also looked backwards and said what was going on in the past. And that's the standard technique. It's been used in different things to predict recurrent thromboembolism. But the challenges of AI are that you might get biased data and lots of data. You have to get population data. You don't know how generalizable it is, because the data you have in those population data may not be available in the next country or may not be collected. We don't know the unintended consequences on care or patient-clinician relationship, and we don't know about costs. And because the decisions are made silently, you can't really say, how did you get to that point? And that's why you need regression. Regression's not gone. Regression will then, we can look back and say, how did we get to that point? Different versions of software give different outcomes. There's there's all sorts of factors, different values every time you execute it. So I'll stop there, Beverly, and just say that there's lots going on. There's lots in the future. There'll be more on factor 11. There'll be more on ethnic groups, more on, I hope, common data elements, the antidotes, AI and MI, and prediction of risk, particularly in cancer patients, but also in non-cancer patients. So thank you very much.
Thank you very much. That was an extremely comprehensive talk about the current and future challenges that we have. And I think we're all very grateful that you have focused on AI, pointing out the many difficulties that there are. It's not the panacea that the press is saying. So an amazing talk. Would you just take a few questions? There are some.
Yeah, be happy to.
So I'll do the first one. Here we go. This is from Zishan. Talking about an XO1, though there's a reduction in hematoma volume, did they measure clinical outcome, mortality, morbidity in the same set of patients who have hematoma? And this is a question because many centres in the UK still are not comfortable using Dexnet in intracranial hemorrhage due to lack of evidence in it affecting clinical outcome. And of course, NICE haven't allowed us to do that yet.
Yeah, well, we did look at outcomes, but we didn't have the power to look at outcomes. So we did look at mortality. We didn't see a mortality difference, but you often don't see mortality differences in clinical trials. And the reason why you don't see them is because the populations are a bit healthier. And when you follow them so closely and they're all getting multiple CT scans and multiple MRIs, you intervene. And you intervene in those who are receiving the treatment, but you also intervene in those that aren't receiving the treatment. And so the actual outcomes of the control arms are much better than what happens in general medical practice. So we didn't see a change in mortality. We didn't see a change in MRS, but you would need a much bigger study to do those things. So we were not powered to look at mortality. We were not powered. We've done some observational data, which shows differences in mortality, and we've tried to balance the groups. We did a small study comparing Orange and Andexanet Alpha, but there was a much bigger study done by Paul Dobesh and Craig Coleman in United States, and they showed that in their hospitals, when they adjusted for risk factors, 50% reductions in intracranial hemorrhage mortality, and 50% reductions in GI bleeding mortality. And we need more. We need to get more experience and collect more data, but we didn't show it in the clinical trial. But that's not expected. Actually, when we did the thromboprophylaxis studies, we couldn't show differences in mortality because in thromboprophylaxis, you are intervening when you diagnose the DVT or the PE, and you're giving them anticoagulation. But in the real world study, and the studies that you've done, Beverly, looking at patients around the UK, you do see differences in mortality. So clinical trials don't show, they're designed to show their primary outcome. And the primary outcome was met very early in this study, a reduction in hematoma expansion, a reduction in worsening of hemostatic efficacy. We got much better hemostatic efficacy with Andexanet Alpha. Yeah, thank you.
Some short questions here. Since Andexanet Alpha is only licensed for apixaban and rivaroxaban, can it be used to reverse edoxaban? It's a yes from me. What about you, Ander?
Well, it's an off-label. I'll start by saying it's off-label. And it's very important to say that. But of course, we've got data from Annexa-4, which we've published, looking at Andexanet Alpha with edoxaban, and the hemostatic efficacy was no different. It was just as good as apixaban and rivaroxaban. There might be small differences because the volume of distribution of edoxaban is quite large. And so I'm not saying it's the same, but we've got some reassuring data. I can't recommend it because it's off-label, but if I had a patient in front of me with an intracerebral hemorrhage and they were beginning, that hemorrhage was showing signs of increasing, and they'd taken edoxaban in the last 6 to 12 hours or whatever, I would be thinking I'd be hard to watch if I had andexanet alpha beside me. Very hard to watch.
Theoretically, it should benefit, shouldn't it?
Oh, it should. There's no doubt. It's just a matter of whether people are going to use common sense or follow the rather restrictive recommendations. Right.
Here's a corker of a question. In GI bleeding associated with rivaroxaban and apixaban, if it is not severe in the beginning and the patient was initially treated with PCC but is not responding, is there a role for andexanet alpha after that?
Yeah.
I did the right answer here.
I mean, the problem. Yeah, look, the problem is that PCC is not licensed for the reversal of anticoagulation in patients receiving apixaban or rivaroxaban. If you're using PCC, you're taking a huge risk because you're acting off license. You're giving a drug which there is no license, and it's known to be associated with more thrombosis. The only thing that's licensed is andexanet alpha in that situation. I wouldn't give PCC, but if that's what you do, sure. I mean, if they're still bleeding, give a drug that works rather than a drug that sort of overwhelms the coagulation system, which is what it does. It doesn't reverse anti-10A levels.
We'd be a bit worried about increased thrombotic risk with that combination.
Yeah, you would. You definitely would.
We're both going to interact. And then the very last question, in non-cancer VTE and DOAC use long-term, is there a leading risk model that is accurate, i.e. a good C statistic? Would you recommend one, Ander?
In non-cancer patients, I would recommend the VTE bleed model. That they had a few cancer patients in that study, and cancer is a risk factor, but it's probably the most specific non-cancer model, and it's been validated. VTE bleed was published by Eric Klock or Frederikus Klock, K-L-O-K. And I think it's a good study in non-cancer and it involved some DOAC patients. So it's probably the best one.
Great, thank you. So we've got 1 minute to 10. What a fabulous hour. You've really stimulated our little grey cells. Thank you so much, and for talking about our possible future in thrombosis. So have a lovely day, Ander, and everybody else on this call, and thank you all for dialing in.
Thank you. Thank you, Beverly. Thank you, everyone. Bye-bye now.